Welcome to part 1 of this 2-part educational video series on the perioperative treatment approach in resectable non-small cell lung cancer. In this video, you'll hear a thoracic surgeon's perspective in a discussion with a medical oncologist.
Hello, I'm Dr. Mark Sosinski.
Hi, I'm Dr. Hari Kashava.
Today we're going to have a discussion on perioperative treatment where we'll hear a thoracic surgeon's perspective. This is certainly a timely topic as more immunotherapy agents are being approved for perioperative use with neoadjuvant treatment before and adjuvant treatment after surgery. Hari, what do you see as the surgeon's role in the early stage setting?
That's a good question, Mark. I think as surgeons, we have to offer patients a chance for curative intent treatment. Unfortunately, we know that early stage non-small cell lung cancer is heterogeneous and often involves micrometastatic disease. Cancer cells that spread beyond the tumor before or during surgery may lead to recurrence. 3-year recurrence rates in resectable non-small cell lung cancer increase 20 points from stage 2 disease to stage 3 disease, as shown on the screen.
So one of the things that I think about is how good we do staging in potentially resectable disease. Sometimes surgeons rely more on CT scans, PET scans for mediastinal involvement. My training was always you have to pathologically document the status of the mediastinal lymph nodes. So is that important to surgeons?
Yeah, for sure. I think understanding the lymph nodes and the lymph node status is extremely important. In my opinion, as surgeons, we have to make sure that if we need pathologic complete staging with endobronchial ultrasound or mediastinoscopy, we should be doing that. In my opinion, also surgeons have to always try to achieve R0 complete resections. Even though that might not always be possible, that should be our goal. Of course, we also want low complication rates for our patients and for the best possible outcomes.
We've known for quite some time that the Achilles heel is micrometastatic disease. What do you think about the strategy of perioperative treatment in resectable non-small cell lung cancer?
Well, perioperative IO-based regimens are intended to work against the cancer cells both before and after surgery. The hypothesized rationale for an immunotherapy-based perioperative approach in resectable non-small cell lung cancer, neoadjuvant treatment may reduce the tumor burden prior to definitive therapy and may target circulating cancer cells. Adjuvant treatment may target any remaining cancer cells that may remain after surgery. In the preclinical models, immunotherapy has been shown to inhibit immune suppression by the tumor, may increase T-cell activation, and may enhance anti-tumor immune response. Chemotherapy may induce tumor cell death, releasing antigens that can help prime the anti-tumor T cells.
You know, in a recent analysis of treatment patterns by Flatiron Health, fewer than 50% of patients with stage 2 and 3 resectable non-small cell lung cancer received IO-based systemic therapy. In both stages, most patients received adjuvant IO in chemotherapy. What do you think are some of the barriers preventing greater use of the neoadjuvant and perioperative IO approach in resectable non-small cell lung cancer?
In my opinion, some reasons could include the lack of a full multidisciplinary team involvement, the lack of medical oncology referrals, some surgeon resistance, patient resistance, and even the lack of surgeons sending to medical oncologists. Surgeons may prefer adjuvant IO over neoadjuvant IO because it may help them avoid losing the patient due to disease progression or complications from systemic therapy.
And then the question is, if your medical oncologist are giving 3 or 4 cycles of preoperative therapy, do you do anything before you go to the OR?
I personally, I do get a repeat PET scan. The only reason is I just really want to make sure we don't have disease
outside the chest. Yeah. So what do surgeons look for in the surgical outcomes data from the perioperative IO trials, and why do they find that important?
I think surgeons are looking for a couple things. One is, with the data, are we able to still get a good R0 resection rate? They want to know that they're still able to do the surgery they want to do, even if they're waiting while patients are getting neoadjuvant chemo IO. I do think surgeons are worried about the surgical delays and reason why patients might be delayed for surgery or reason why patients might not get to surgery. I think understanding that very well, making sure we understand if a patient is operable even before getting neoadjuvant chemo IO versus even after, and doing the appropriate due diligence on understanding these patients, making sure that they're getting the adequate tests that are needed before operation. I think we all have to do that as surgeons. And lastly, I think surgeons want to know what's actually happening to their patients, meaning, is the chemo IO and adjuvant therapy actually helping their patients overall?
It's been pretty consistent in the perioperative clinical trials that about 15 to 20% of patients don't make it to surgery.
I think it depends on patient selection. If we, as practitioners, do a good job and we try to decrease that medically inoperable cohort of patients, then hopefully that number will even go down too. So that's why I try preoperatively to really make sure, are they truly surgical candidates even before their treatments, and even during the treatments. I'll make sure I at least see them once while they're getting their chemo IO to see how they're doing, making sure there's not some other issues from their treatment that they're having before I even get them to surgery.
That concludes the first part of this two-part video series. In part 2, the thoracic oncology experts will discuss appropriate use of perioperative treatment in resectable non-small cell lung cancer. Be sure to view the second video at the URL on the screen.